This video will throw light on the nomenclature and grading of peripheral blood smear morphological features. Now, abnormal morphologic findings are reported in various ways. Can be as a simple description, by the use of terms such as present or absent, by a semi-quantitative determination like mild, moderate, or marked, or by a quantitative percentage of abnormal morphological findings like normal, mild, moderate, or marked. Although certain morphological abnormalities, for example cystocytes, will have a greater significance at lower percentage numbers than other abnormalities such as hypochromia, and this is reflected in the proposed grading criteria. According to the latest guidelines given by ICSH in 2015, the morphology grading contains a two-tiered grading system for moderate as 2+ and for many as 3+. The designation for few or rare as 1+ is reserved only for cystocytes, as the observation even in small numbers is clinically significant. First, we will start with RBC morphology. Automated analyzer peripheral blood counts provide accurate and precise RBC counts and red cell indices, information on RBC population distribution, size, and hemoglobin content in a stained peripheral blood film. Normal RBCs are on average 7.5 microns in diameter and round or slightly oval in shape, with an area of central pallor occupying approximately middle third of the cell. According to Rumpke distribution table, a minimum of 1000 red blood cells should be evaluated to provide a precise percentage of cells having a particular morphological abnormality. As a general recommendation, the ICSH group recommends providing only a qualitative report for those presenting with RBC abnormalities. However, a cystocyte count may be of clinical value for the diagnosis and follow-up of hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. RBC abnormalities can be divided into 4 parts. First, irregular distribution of red blood cells on the blood film. Agglutination is the irregular clumping of red blood cells into grape-like clusters, usually indicating the presence of cold reactive anti-red blood cell antibody, which might lead to factitious elevation of MCH and MCHC. Rouleau formation is the stacking up like a pile of coins of red blood cells, usually occurring when plasma protein concentrations are high. For agglutination and Rouleau formation, the recommendation is to report the presence when observed. Second, abnormalities of RBC size and or color. Anisocytosis is an increased variability in RBC size. It is non-specific and is reflected in increased RDW. The recommendation is to use and report the RDW. However, anisocytosis can be graded if an RDW is unavailable. Dimorphism is the presence of two distinct RBC populations, which may be clearly seen on an analyzer red cell histogram with a corresponding increase in RDW, commonly seen in combined nutritional deficiency and nutritional deficiency on treatment. The recommendation is to report the presence of dimorphism and describe the two populations. Hypochromia is the reduction in RBC staining with an increase in central pallor to greater than 1/3 of RBC diameter, reflected in decreased MCH and decreased MCHC. The recommendation is to gauge hypochromia based on MCH value rather than grading, but grading can be used in labs who prefer to grade based on visual inspection. Macrocytes are enlarged red blood cells with a diameter greater than 8.5 microns or having MCV more than 100 femtoliters. They may be round or oval in shape, which can have a diagnostic significance. Microcytes are small RBCs with a diameter of less than 7 microns or having MCV less than 80 femtoliters. It is recommended that MCV be used to gauge RBC size rather than grading, but grading criteria is included for those labs which don't have analyzers. Oval macrocytes, if present, should be graded separately. RBCs of newborns and neonates are larger than in adults, but the RBCs of healthy children are physiologically smaller than in adults. So it is important that RBC size be interpreted in the context of age of the subject. Polychromasia refers to immature red blood cells that are pinkish blue to grey in appearance due to residual ribosomal RNA and are larger than normal mature red blood cells. The recommendation is to grade polychromasia and perform a reticulocyte count if necessary. Third, abnormalities of RBC shape. Acanthocytes are round, hyperchromic red blood cells with 2 to 20 irregularly spaced projections or spicules of variable length, thickness, and shape. Some spicules have club shape rather than pointed ends. Bite cells are red blood cells with peripheral single or multiple arcuate defects caused by removal of Heinz bodies by the spleen and are a feature of oxidant hemolysis. Blister cells are red blood cells in which the hemoglobin appears retracted to one half of the cell to form a dense mass, leaving the remainder of the cell as an empty membrane. Echinocytes, also known as Burr cells, are red blood cells that have lost their disc shape and are covered with 10 to 30 short blunt projections or spicules of fairly regular form. Elliptocytes are cells with elliptical shape having the long axis more than twice the short axis, while ovalocytes have an oval shape having long axis less than twice the short axis. Irregularly contracted cells are smaller and denser red blood cells which lack an area of central pallor but are not as regular in shape as spherocytes. Poikilocyte is a red cell of abnormal shape and may be associated with a particular disorder. The recommendation is to report the abnormal specific shape rather than using the term poikilocytosis. Cystocytes are fragments of red blood cells produced by extrinsic mechanical damage within the circulation and are a diagnostic feature of microangiopathic hemolytic anemia. Cystocytes are always smaller than intact red blood cells and can have the shape of fragments with sharp angles and straight borders, small crescents, helmet cells, or keratocytes. Microspherocytes may also be a feature of microangiopathic hemolytic anemia if it is accompanied with other forms of cystocytes. The recommendation is to grade cystocytes. A cystocyte count may be of value when cystocytes are the dominant feature for the diagnosis and follow-up of microangiopathic hemolytic anemia. Sickle cells are red blood cells that become crescent or sickle shaped with pointed ends as a result of polymerization of hemoglobin S. Spherocytes are of smaller diameter, that is less than 6.5 microns, and are dense spheroidal red blood cells with a normal or decreased MCV and an absence of central pallor. They may be formed as a consequence of an abnormality of the red blood cell cytoskeleton and membrane, immune and microangiopathic hemolysis, and direct damage to the red blood cell membrane. Stomatocytes are uniconcave cup-shaped red blood cells that appear on a stained blood film with a slit-like area of central pallor. Target cells are thin cells with an increased surface area to volume ratio that have an area of increased staining which appears in the middle of the area of central pallor. Teardrop cells are red cells that are pear or teardrop in shape. The recommendation is to grade acanthocytes, bite cells, blister cells, echinocytes, elliptocytes, irregularly contracted cells, sickle cells, spherocytes, stomatocytes, target cells, and teardrop cells. Coming to fourth, that is inclusions in red blood cells. Basophilic stippling describes the occurrence of fine, medium, or coarse blue granules due to abnormally aggregated ribosomes uniformly distributed throughout the red blood cells. Howell-Jolly bodies are usually single, small, about 1 micron in size, dense, perfectly round basophilic inclusions, and are fragments of nuclear material. Intracellular hemoglobin crystals are crystalline aggregates of hemoglobin that may be seen in hemoglobin C and hemoglobin SC disease. These crystals stain densely, vary in size, and have straight edges with pointed ends. The recommendation is to report the presence of intracellular hemoglobin crystals when observed. Microorganisms in red blood cells may be seen free between or within red blood cells in patients with bacterial, fungal, protozoal, or parasitic infections. The recommendation is to report their presence when observed. Malarial species identification should be made and reported. For patients with malaria, determination of parasite density is useful in clinical management and in monitoring a patient's response to treatment, particularly in Plasmodium falciparum and Plasmodium knowlesi. Pappenheimer bodies are ferritin aggregates in red cells, visible in Romanowsky stained peripheral blood films as multiple basophilic inclusions of variable size, shape, and distribution, usually in a limited cytoplasmic area. They stain positively for iron. The recommendation is to grade basophilic stippling, Howell-Jolly bodies, and Pappenheimer bodies when present. Nucleated red blood cells are red cell precursors and they describe an erythroblast in peripheral circulation. The recommendation is to report NRBCs as absolute count within the differential with the WBCs corrected for the presence of NRBCs.